I first invite Dr. Vijay Tomar to give his talk on pattern identification in choroiditis. Dr. Vijay is a senior consultant in Chitrakoot Eye Hospital.
No, I was at Sitapur Eye Hospital.
Sorry, Sitapur Eye Hospital. I'm sorry for that.
So, good morning, everybody. Thank you, AIOS, for giving me a chance in this academic feast related with cells and flair. So, in our day-to-day clinical practice, we encounter the patients of choroiditis. And sometimes the situation is like this, that this is really very difficult to tell that this is choroiditis or an entity which is closely mimicking with choroiditis. So this was a gentleman of 28-year-old who was treated elsewhere with steroids for supposed to be a choroiditic lesion, but the vision deteriorated, and on investigation what we found that it was a case of multifocal CSCR, which was actually thought as a choroiditic lesion. Then again, this is a 32-year-old lady who was treated elsewhere with steroids for serpiginous choroiditis, but the patient was not responding. We investigated and we found that this was a case of choroidal osteoma. So in such scenarios, it is really very difficult to assess that whether this is a choroiditic lesion or a non-choroiditic lesion, and the real problem occurs to decide whether this is a choroiditic lesion or a retinitis lesion, and I think that Dr. Mudit has very well illustrated that difference between the retinitis and choroiditis in the previous session. So if it is a choroiditic lesion, we will have to decide that whether this lesion is a solitary lesion or the lesion is a multifocal one, or whether the lesion is associated with neurosensory detachment. Now coming one by one. So if we see a patient having dense vitritis with focal necrotizing choroiditis, giving typically a headlight in the fog appearance, we should suspect that it's a case of toxoplasma, and when the lesion is healed, it gives a typical cartwheel appearance due to well-defined borders with central retinochoroidal atrophy and peripheral RPE hyperplasia. We can see the choroidal vessels of Bayer's sclera in the atrophic central area. But sometimes this toxoplasma can present with satellite lesions, and the reactivation of lesion is usually seen at the margin of the old scar. And when the element of vasculitis is there, we can see the pattern of chyliosis arteritis. The lesions of toxocora also has vitritis, but the amount of vitritis is lesser in comparison to the toxoplasma. Mostly we see a white grey round elevated lesion of 1 to 2 disc diameter size at the posterior pole in the vicinity of disc or in the subfoveal area. But we can also encounter a peripheral granuloma which appears as a hazy white elevated reaction in peripheral fundus associated with retinal fold, which may extend from peripheral mass to optic nerve head. Since we are living in India, which is very much prone to have tuberculosis, so we should always think of tuberculosis while dealing with choroidal lesions, and tuberculosis can present as a large tuberculoma ranging from 3 to 14 millimeter in size, presenting as a subretinal mass with surrounding subtle serous retinal detachment. But we can also encounter multifocal lesions of tuberculosis, starting from the lesions like millets to 1 disc diameter with indistinct border and surrounding edema with or without hemorrhages and exudate. Sometimes tuberculosis can present as a subretinal abscess, which actually presents as a solitary yellowish-white circumscribed mass-like subretinal lesion and often associated with overlying retinal hemorrhages. As Reema madam has discussed about the serpiginous choroiditis, the lesions of serpiginous choroiditis presents with irregular, grayish-white, creamy in nature, seen near the optic disc and extending centripetally in a pseudopodial or serpentine manner, but without vitritis. Non-contagious skip lesions has also been noted, and healed lesions shows extensive chorioretinal atrophy. Active lesions are usually found at the border of inactive lesions and appear in an interlocking polygonal pattern that spreads out to the periphery. Again, the serpiginous-like choroiditis, how to differentiate with serpiginous choroiditis? The element of vitritis is present in the patients of serpiginous choroiditis. It is thought to be immune-mediated hypersensitivity reaction in the presence of acid-fast bacilli in the choroid or RPE, and the lesions are almost similar to the serpiginous choroiditis. Sarcoidosis closely mimics tuberculosis and they can present as a solitary granuloma, but in majority of the patients, the lesions are usually small, discrete white spots of 1/3 disc diameter size to pinhead size in clusters around the venules and often limited to 1 or 2 retinal quadrants, frequently inferior and nasally. But they can also present as yellow-orangish lesions located at the level of choroid, predominantly in the posterior and nasal fundus. Sarcoidosis can also present as an optic disc granuloma and in the form of neuroretinitis, and when element of vasculitis is there, we get a typical candle wax strippings-like appearance. Now, multifocal choroidal lesions. Multifocal choroiditis with panuveitis, as the name suggests, the lesions are multiple. They are oval yellow grayish lesions seen throughout the posterior pole and mid-periphery, and they have a distinct propensity for a peripapillary and nasal, mid-peripheral and peripheral distribution of these lesions, and optic nerve involvement is seen in around 1/3 of these patients. Multiple evanescent white dot syndrome is usually unilateral, and they are very subtle, small lesions seen over the posterior pole, involving in the perifoveal and peripapillary regions, and they are best appreciated by slit lamp biomicroscopy, and uniform macular granularity is the hallmark of mutes. APMPP is usually bilateral, but sometimes the other eye involvement may take several weeks, and these are placoid yellowish white lesions seen over the posterior pole and extending up to the equator. The punctate inner choroidopathy is commonly seen in young myopic females, and multiple discrete flat yellow round lesions are seen at the posterior pole. With the time, they are either faded with chorioretinal lesions or atrophic chorioretinal scar. But remember that absence of vitritis, cystoid macular edema or disc edema is not seen in the patients of PIC as we see in the patients of multifocal choroiditis or mutes. Amphigenous choroiditis mimics placoid lesion of APMPP and Quercus lesions of serpiginous choroiditis. Suspect VKH and sympathetic ophthalmitis if we are seeing a patient who is having bilateral disc edema with multiple exudative retinal detachment pockets with anterior and vitreous inflammation. In the convulsant phase of VKH, we get typically sunset glow fundus, and in the patients of sympathetic ophthalmitis, we get Dehlen-Fuchs nodules, but remember that these are seen only in 1/3 of these patients. And the history of trauma actually differentiates between the VKH and the SO, and systemic features are more commonly seen in VKH than in the patients of sympathetic ophthalmitis. So now summarizing, if we are having solitary lesions with vitritis, think of toxoplasma, toxocara, sarcoidosis, tuberculosis, and mascaraders. If we are seeing solitary lesions without vitritis, think of serpiginous choroiditis and mascarades. If we are seeing multifocal lesions with vitritis, think of multifocal choroiditis, mutes, SO, and VKH. If we are seeing multifocal lesions without vitritis, think of APMPP, PIC, and amphigenous choroiditis. And if we are seeing the patients of neurosensory detachment, think of VKH, SO, and mascarades. So the take-home message is that meticulous clinical evaluation of choroidal lesions helps in determining the clinical entity. And these are my acknowledgements. And thank you so much.